And if we could start off with some introductions. Renee, would you mind introducing yourself again to the group?
Sure. Renee Bolio Banks Indigenakaj, Shaganashiman. My birth name is Renee Bolio Banks, specifically Indigenakaj. Indigo is my Indian name. It's for a woman. I'm from Leech Lake. I'm Eagle Clan. I've been at NACC for about 5 years. I'm the elder in residence, and I love the work I do and the people I work with. So welcome. Miigwech.
Which, Dr. Robbie?
Yes, hello, my name is Kari Robbie. I'm a family practice and addiction medicine physician here at NACC, and I've been working with the MAT program since 2016.
Nikki?
I'm Nikki Jardina. I'm the infectious disease nurse at NACC.
Thank you. And I'm Lindsay King-Cooney. I'm the community and tribal engagement specialist here at NACC. And I'm going to do a couple of announcements before I hand it over to our speaker today. Share my screen. So welcome. This is the Midwest Tribal Echo. We're the Opioid Use Disorder Education and Treatment Series. And today we have Anna Steiner. She's the National Program Manager for the Transitions Clinic Network that will be talking to us today. So we're the Native American Community Clinic. We were established in 2003. We're an FQHC located in the heart of the South Minneapolis urban Indigenous community. This is just a list of our current open positions at NACC. So down at the bottom, if you go to our website, you can read more about those job descriptions. Some session guidelines, please know protected health information. If you're willing to turn on your camera, we'd love to see your faces. If you could mute yourself if you're not speaking, that would be great. And then if you could let us know who you are in the chat, so your name, title, organization, and email, I can send out information to you after the session. And we also welcome you to use the chat if you have any comments or questions, and we'll get to those at the end of the presentation. This is important. So we do have a new iEcho format coming. So this will be our last session of the year, but starting January 3rd, you'll have to register for iEcho to join the sessions. So there's a QR code there that you can use, and then I can send out the link, and I can put the link in the chat. It just takes a couple of minutes to sign up, name, email address, and then you're all set to go. And then our next echo will be January 3rd with Nikki Jardina talking about safer drug use. So no more echo for the rest of December. And then this is a list of other echoes that we recommend by Hennepin Healthcare, Indian Country Echo, and Stratus Health. And then we do offer continuing education credit for those who are eligible. You just have to fill out the post evaluation survey, and I'll put that link in the chat as well. And I think that's all for me. I'm going to stop sharing, and then I'll hand it over to Anna.
Great, thanks so much. Thanks for the beautiful blessing, Renee, and thank you, Lindsay, for inviting me. I'm going to go ahead and share my screen really quickly here and get started. So I'm going to go through a lot of information somewhat quickly, and with the hopes that we'll have some time for questions at the end too. And I would love, I feel like there's probably so much expertise in this Zoom room here. So really hope to get to hear from folks as well. As Lindsay had said, my name is Anna Steiner. I work for Transitions Clinic Network. I'm here today to talk a little bit about our work, trying to transform health systems to better serve individuals returning from and impacted by incarceration. I'm sitting here, I'm in Oakland, which is unceded Ohlone land. I just want to acknowledge that, particularly on this call. So we are based in California. But we are a national capacity building organization, and our mission is really twofold. It is to transform health systems that are dedicated to serving individuals, to improve the health and well-being of individuals returning from incarceration, as I stated before, and also to promote job opportunities for formerly incarcerated individuals in community health systems. So sort of dual visions around just mitigating mass incarceration within our communities. I love that Lindsay already did this. So I love everybody. It looks like everybody's putting their name and chat and sort of their position, which is great. Gives me a better sense of who's sitting here with us. I have pretty lofty learning objectives for a 40-minute session, but here, hopefully we will meet these. I'll let you all read through these, but essentially, I'm here today to talk a little bit about mass incarceration, which I'm assuming in this room, there's also a lot of expertise around that. So I'll do a brief sort of overview of the impact of mass incarceration, the unique challenges that people face upon reentry, particularly and especially folks with substance use disorder or people in need of care for substance use disorder. And also talk a little bit about the work that we do, and hopefully we could think strategically as we're going through this of ways that you're serving this population already and ways that you could potentially improve services for folks in your community returning from incarceration. So a little bit about the impacts of incarceration. Just going to do a case, sort of weave this through. So Mr. Jones, a 67-year-old man with type 2 diabetes, chronic low back pain, major depression, and a history of opioid use disorder, shows up at your clinic. They were released from prison a week ago. They're staying in a halfway house, we say from Minneapolis. Here we have Los Angeles, but they lost contact with all their family members during incarceration. They were not released with any medications. They take 7 different pills. They know that from their pill line, but they're unsure of any of the names or dosages except for Suboxone. Additionally, Mr. Jones arrives 45 minutes late to the appointment because he got lost on the way to the clinic. He had to get off the bus once it got crowded because he started having a panic attack. And you only have a 15-minute appointment scheduled for him, and you have 3 patients waiting. So question for you all, what is the likelihood of a primary care provider encountering a patient like Mr. Jones in their clinical practice? Go ahead and if you can put your sort of the A, B, C in chat, D, from your experience. Folks seeing this? Well, I think so. In our experience, I'm not seeing, for some reason, I'm not seeing the chat. CD, thank you. Yes, thank you. In our experience, actually, the answer is D. C and D, exactly. Like we see that most clinics don't actually ask patients about their histories of incarceration, right? So you may be seeing people in this who are having this experience, but you may not know because clinics aren't screening. And then C, most clinics do have that 15-minute late policy, right? So you may never actually see this patient. So first, just wanted to talk a little bit about the impact of mass incarceration and what that looks like in this country. I think this helps set the stage for why we do the work that we do. We, as people probably know, the United States, we are the largest we incarcerate more people per capita than any other country in the world. This just shows us in comparison to other supposedly developed nations, but this is a huge issue in the United States, right? And it is also like a huge health issue. And also, we know because of the policies that have actually promoted and perpetuated mass incarceration that punish communities of color, Black and Brown communities, that incarceration really impacts certain communities much more disproportionately than others. This graph shows American Indian, American Native, Alaska Native populations in particular are very heavily and disproportionately impacted by incarceration. And actually, what I don't show here is among women, actually, American Indian, Alaska Native women are more impacted, disproportionately impacted than any other racial ethnic group in the United States. So this is absolutely an issue that is impacting the communities that you all are serving. I think also another thing to think about is the policies that we've created that have led to this huge increase in incarceration are also fueled by sort of criminalization of certain health conditions, one of which is absolutely substance use disorder. You can see in this graph sort of the disproportionate amount of individuals who are experiencing incarceration in jail that have a diagnosable substance use disorder. We know that in our state prison system here in California, they estimate that 70% of individuals incarcerated have a substance use disorder. And then also similarly with serious and severe mental illness, people who are diagnosed with serious and severe mental illness are much more at risk of incarceration. And that is because of policies and laws that have been enacted that really can criminalize behaviors that people may exhibit, or just, very small offenses. We also, I think I look at this as healthcare providers, and I can't help but think, if we're able to, how we might be able to prevent some of these cycles of incarceration, right? If we're able to get folks into and connected to the services they need and deserve. And then I think it's also just important to look at the reach of the criminal legal systems. We have so many people in prison and jail, as you can see here, and this is actually from 1980. Sorry, I didn't label this the graph, but the black bars are 1980, the red bars are 2000, and you can just see that the sheer increase in the number of people who are not only incarcerated currently or at that point in time in the prison and jail system, but also the number of people who are on what's called community supervision. And the important thing to note around community supervision is you are not actually technically a citizen when you are on community supervision. You may not have the right to do specific things. You are under control of the criminal legal system. You have certain restrictions that may impact where you live, whether or not you receive food stamps in some states. So there are things that you need to do, and there have been instances of people not being able to use medications for opioid use disorder who have been on community supervision. I don't know if that's still an issue, but that has in the past been an issue in certain areas. So it can impact many things about your life. So just broadly to demonstrate how huge of an issue this actually is. Oops. And these pictures here are just some pictures from our state prison system in California, just to kind of share the experience of what it is like for people when they're incarcerated and how that may impact their interest in actually engaging in services or their sort of baseline ability to access services when they come home. People who are incarcerated actually have worse health than people in the community, which has a lot to do with people's ability to access care pre-incarceration as well. But I think it's important to note that, folks who are incarcerated have higher rates of almost all chronic conditions, HIV, hepatitis C, and so on and so forth. So it's really important to note that if you are seeing folks coming home, folks do have worse health who are incarcerated. And the environments themselves, this is actually a picture from a gym. This was meant to be a gym in the California State Prison. This was before there was a major lawsuit that put our state under federal receivership because one person per week was dying due to medical negligence in our state prison system. At that time, we were over 200% capacity in our prison system. So you can imagine if you're coming into the system here, let's say you're in withdrawal, right? How horrible would this be? Or you have the flu. So really some of these carceral environments that people experience can exacerbate poor health. And we particularly would see this around folks with substance use disorder and mental illness. Also, people might partake in risk-taking behavior that you wouldn't in the community because there's no such thing as harm reduction, right? Like we know there's drug use inside a carceral setting, so people share syringes or through tattooing. So it really fuels things like the spread of hepatitis C as well. And then access, well, you're constitutionally entitled to healthcare when you're incarcerated. Unlike sort of anywhere else in our country, anybody else, there is a constitutional mandate to receive healthcare services. The actual services that people receive are definitely subpar in most ways. And this right here is what they call therapeutic pods. So this is maybe the only way that how people access mental health services is they're actually like put in these therapy pods, what they call them. This isn't everybody. This may be a certain individuals, but still the fact that this is seen as sort of a way to provide services to individuals inside may sort of hint to why people may not be inclined to receive services when they come out. And I actually showed this slide once at a presentation, and there was a nurse from a prison. The prison was there, and she, raised her hand and said, "Yeah, but this is only for like the worst people. We don't do this for everybody." And I'm like, yes, but the fact that this is actually considered a therapeutic service for anybody doesn't make this acceptable, right? So I think this just shows, there is access to services. People do have access to care, and maybe, and that mandate, but it is very difficult for people to access services in a lot of ways, and the services that are available may not meet their needs. And I think a thing to note when you're working with the community is, there is no real self-management. Everything is done through the institution. You go to pill line, like Mr. Jones, you may not know what you're taking pills for. You never learn, if you're a diabetic, you may not learn how to inject your own insulin. If you are getting medications for opioid use disorder, you're going to the pill line to get it daily. You're not, in fact, you may be discouraged from trying to be proactive about your own healthcare. So it's really difficult when folks come home. They don't come home with sort of a baseline knowledge many times around how to access community services. And folks are, systematically silenced. You're discouraged from asking questions. You're not engaged in your own healthcare decisions. You don't have access to the internet. You don't have access to other folks really to get information about healthcare or, other modalities available. So I think also people may maybe really become institutionalized when they're inside. And even, folks are jumping in and out of jail, you sort of come home and may have the perception that nobody's listening to you, and that you don't have any voice in your own healthcare decisions. And I think, like, most importantly, 95% of people who are incarcerated come home. So this is actually very much a community issue, because almost all of the folks that are being incarcerated are going to come home to our communities. All right, and then, folks encounter some very specific reentry related challenges. So let's go back to Mr. Jones. Thinking of all the issues that he's dealing with right now. What issues do you think would pose the greatest risk for Mr. Jones when immediately upon release, when he's coming into the clinic? Feel free to type things into the chat. There's no wrong answer. All of the above, all of these. Yeah, basically all of the above. When people return from incarceration, their health gets worse, actually. There's a protective factor of being inside. Like I was saying, you have a constitutional mandate. There are healthcare services, you have meals, you have a bed. So research has shown that when people actually get released, their conditions worsen. Folks may go off their antiretrovirals. There's an increased risk of hospitalization and a huge increased risk of death. There was a seminal study that was done in the state of Washington, which found that individuals returning from prison, as compared to a large cohort of individuals in the community, same demographics, same health conditions, that were at 12 times increased risk of death in the first 2 weeks after release. So this was from a large cohort of individuals returning from the state prison system. And the leading causes of death were drug overdose, cardiovascular disease, homicide, suicide, and cancer. So thinking back to Mr. Jones, definitely drug overdose is the number one cause and a huge risk of people when they come home from incarceration. I think the thing that strikes me when I look at this is that these are almost all things that could be mitigated in our community health systems, right? If we were able to actually connect with individuals and provide the services that they need. Once again, back to sort of the preventative thing. But the reality is that people encounter so many challenges in connecting with care that most folks aren't able to access the services they need. And this also has driven the work that we do, which really centers around trying to engage and outreach and get people into care before they're susceptible to death or hospitalization. Some of these health-related reentry challenges are, the continuity of care. Many places don't have any sort of discharge planning initiatives. People's health records don't follow them. You think back to Mr. Jones, you may have no medications upon release or very short supply. Folks Medicaid and Medicare may lapse when you're inside, or you may have not had health insurance. So when you come home, you may not have any insurance to rely on. Also, we always like to talk about when you're coming out, there's all these other needs that need to be addressed. We think of all the people on community supervision. You may need to go see your probation officer, your parole officer. You need a job, you need a place to live. So even if your health is the number one thing that you're thinking about and that you're concerned about, there are all these other things that are, may take priority when you get home. And then I think another huge thing is the discrimination and stigma. We know that individuals experience all sorts of discrimination in the healthcare system based on race, ethnicity, history of drug use, history of homelessness. And there's also been studies that have found that individuals who have been incarcerated are discriminated against in the primary care system. So I think the fear of stigma and discrimination is another huge challenge. And just some, additional substance use disorder related reentry challenges, like on top of those other ones, there are similar challenges. Also, people not getting referred to the proper level of care in the community for substance use disorder. We see people returning to communities without access to MOUD. We see folks being put on MOUD and coming out with a prescription for their buprenorphine without any insurance set up, right? So no way to actually get the buprenorphine when they come home because their insurance isn't active. And we also know there's just increased stigma and discrimination that people have faced, people with substance use disorder have faced in health systems. And then I think also just the criminalization of drug use is just a huge challenge and issue for folks. And I think, we always want to talk a little bit about the collateral consequences of conviction. These are the things that also create barriers to people receiving care. These are things that people face after they have served their time. that impacts all aspects of their life. There are 44,000 collateral consequences that individuals who have done their time may face when they come home, and they most heavily impact individuals' ability to get employed. So I think, just want to make sure that when we're serving folks who are coming home, we're aware of all these other outside factors that may be impacting their capacity and ability to healthfully reintegrate, access care, and move forward and address other social determinants. So, just wanted to provide that background in order to talk a little bit about our work. So, our work, if we go back to Mr. Jones, he was, remember, we all remember Mr. Jones. What do you prioritize if you're seeing Mr. Jones for the first time? What would you prioritize during your 15-minute visit with Mr. Jones? This is sort of a trick question, because if you have 15 minutes, how are you supposed to address all of these issues, right? I think this is the root of the work that we do, by transforming systems. And I think one thing, I love that. What does he want to address first? I think that's a great answer. I think, I think something that we also, like to not take a nod to is, even with an increase in sort of access with the ACA, with the expansion of Medicaid in most states, that is not enough for the reentry population. What we've seen is that even when people are given access to insurance, and have capacity to see primary care providers, there isn't necessarily an uptake in care. And we've seen this particularly around substance use disorder and mental health services. So I think one thing that contributes to sort of the background of our work as well, in transforming community health systems. So we started this work in 2006, and it was really a nod and acknowledgement to this piece that improvement in access to services didn't actually result in folks coming to primary care clinics to receive care. We've had low-income health plans here in San Francisco since way before 2006. And we realized that we were working within a health system that was heavily impacted, in a community heavily impacted by incarceration. But patients were only coming to the primary care clinic after going through the emergency department, which made us wonder, why are people not accessing care in primary care services? And what could the primary care system do to better address and assess the needs of individuals returning home? Like, what doing wrong, and how can we fix that? So we worked with advocacy groups, folks who are impacted by incarceration, amazing advocacy group here. We did a series of focus groups, and really with the intent of wondering, what would a system that was informed by and addressing the needs of individuals impacted by incarceration, what would that look like? What were we missing in the community health system? How could we engage folks in care and try to prevent overdoses, try to make sure people had their hypertension meds, try to make sure folks were connected before any negative health impacts, try to reach people truly where they were at. And these are probably not, this isn't rocket science. These are probably things we all know, right? But really, these informed the program that we made, which is called the Transitions Clinic Network Program. The community was like, we need to include the individuals and communities in every element of the program. Folks also wanted us to, we have to incorporate a broad definition of health and well-being. It wasn't just about getting your medications refilled, right? It's about, spiritual, social determinants, making sure folks' actual well-being and whole person care needs were taken care of, particularly since everything is so up in the air when folks are coming home. The need to empower patients, especially since people have been really institutionalized, just a real emphasis on how do we teach people to have self-determination, to advocate for themselves. And I think one interesting lesson we learned was when we started, we were offered some space across the street from the jail. And we went back to our community. Our community said, no way. Nobody wants to just go straight from jail across the street to the clinic, right? We're like, ah, great, free space. So all of our programs are actually within existing healthcare systems that are in communities that are disproportionately impacted. So our work is all centered around existing systems in communities that are impacted. So folks go to the clinic that their grandchildren go to, you know, that their neighbors go to. And a lot of our work also goes into working with clinics to make sure we're avoiding the replication of carceral systems, if at all possible. You know, if you think back to Mr. Jones coming 15 minutes late to the clinic after having a panic attack, getting on the wrong bus, you know, maybe showing up, maybe not knowing that they needed to check in at the front desk. If they're not seen by the clinic that day, they may never come back, right? Because that may be interpreted very differently by Mr. Jones or somebody who's been institutionalized than by somebody else who's understanding of these systems and understands the limitations. So a lot of the work is about reflecting around what are things that our system are doing, and seeing if we could address those. Like sometimes it's not possible to change the 15-minute late policy, but is there a way to make sure that somebody's able to check in with the patients and provide something, whether it's like some food or a bus token? So as I said, you know, we were developed in 2006. Our model of care is really an enhanced primary care model, like I was saying, integrated into existing health systems. And it really centers around an interdisciplinary team that includes community health workers with lived experience of incarceration. So when the community told us we really need people who have been impacted by the systems to be involved, what we came up with was that a TCN program is led and integrates a community health worker with lived experience of incarceration. So that is a core tenet of our work, is every program we work with has and integrates a community health worker with that shared lived experience onto the team. They're involved in all aspects of the program development, evaluation, and work to outreach to the other systems that folks may be involved with and engaged in. So, you know, most of our programs are within federally qualified health centers that offer integrated mental health services, primary care-based SUD treatments, including medications for opioid use disorder. I think that's a huge piece that we try to make sure that if clinics are not already offering that service, that there is a way to integrate that into the program, because we know that substance use disorder is such a huge issue among folks coming home. And then I think a real sort of piece around the model is also sort of trying to break through what are traditionally very static clinic walls to develop relationships with untraditional partners, to assure that individuals' whole person needs are taken care of, right? You know, and that's a huge piece of what the community health worker does, is they're able to sort of reach out and develop relationships with community-based organizations. You know, we partner with probation and parole, not to provide information back, but to get referrals from them, right? And also to, you know, advocate for patients to understand better what their needs might be. And then also working with hospitals and public health systems. And sort of just showing you, this is like a series of sort of showing you some of the functions of the community health worker. Like some of our programs, a huge piece can be in reach, actually developing relationships with individuals before they're released. We actually see this as a best practice. It's not, and not everybody or clinic is able to do this. But it's pretty amazing when the community health workers are able to go inside. These are actually providers, to connect with folks pre-release, and then connect with people immediately upon release as well. You know, the community health workers, and I'm curious to hear if folks have community health workers in your clinics as well. Do outreach and engagement, right? Like this is a community health worker going to the hospital to reach out to patients. Many of the patients don't have any family. So just that having that flexibility spend 50% of the time out of the clinic going to see patients in their homes, in the hospital, help. And just like with navigation, we had an occasion once where there was the custodian came up to the provider at the end of the day and said, this individual has been sitting in the waiting room all day. And it turned out this person had come for their appointment, had shown up early, but had never been to a community health clinic before and didn't realize they had to check in. So they were sitting all day in the waiting room because they had no idea that you had to check in to let the staff know they were there. So now it's like the community health workers will always go out into the waiting room to meet patients and make sure they know the system, to be greeted, you know, and we'll accompany patients in with the provider if the patient is interested. There's a huge and understandable amount of distrust and mistrust of health systems, and many times among folks who have been incarcerated. And, you know, because the health system is still a system and people may have been harmed by these systems in the past. So having an advocate or somebody who's been there and understands the system to really act as, we say, like a cultural interpreter and actually come in the room with you, go over a list of stuff with you, is a huge piece of this work as well. And facilitates trust. Like the community health worker can vouch for the provider as well and be like, look, they're cool. You know, this is their work. They're working with folks who are coming home. They're invested in us and invested in serving us, and I'll be there to support you. And then the piece around health promotion and self-management support, you know, not everybody is incarcerated for long periods of time, but a lot of folks never learned how or when to take medications or what they're taking their medications for. Or, you know, like if you're on medications for opioid use disorder and you get started on them, and if your correct carceral system is doing that, we were seeing a lot of folks who are actually on a subclinical dose in the system. So if you come home and you've got cravings, you know, and you don't understand, you can advocate for like a higher dose of buprenorphine if you're not feeling the effect. Like these are the things that it's really important that the provider probably doesn't have time to tell you, but the community health worker can help educate on. Then also, you know, helping folks with those other needs. It's not just about the medications, right? It's about, you know, many of our clinics have food pantries or have clothing for folks, or do outreach and bring people food. This is Ron with one of our clients who's experiencing homelessness, just to make sure he's got some nourishing food. Technology is a huge issue, so coaching. And then there's that emotional support, mentorship, and family reunification. I think this is particularly pertinent and can be challenging and also the most meaningful with folks who do have substance use disorder. A lot of times, even if people, and you all know this, are in recovery or participating in programs, folks may have lost their community or family or a lot of the social support and may not have anybody available to just reach out to when they're having a hard day. So we see that community health worker can really, and a peer support specialist, right, in many places can really play that role, which is invaluable, and help people with family reunification. And then the piece I think that's really powerful to me is our programs really participate in a lot of systems advocacy. In fact, I am thinking right now, we have a program at Hennepin Health, which is particularly focused on medications, working with folks coming from jail who are on medications for opioid use disorder, and making sure they're linked to treatment in the community. So that they're doing amazing work. I was hoping they could join us, but they weren't able to be here today. They're serving an amazing, like a huge population of individuals. And one thing, you know, that is an interest in advocacy piece that they had taken on was there's very restrictive hiring practices in Minnesota around hiring individuals with lived experience of incarceration. So this is not specifically a patient issue, but this is an issue that patients will run into. And they've really gone to bat and have been trying to change policies around hiring in health systems and like bring some visibility to the fact that, you know, with the state law in Minnesota, very, very strictly restricts and limits who you can hire, and individuals with even very minor convictions are not able to be hired within health systems in Minnesota. So I think of pieces like this as a huge piece of the work as well. So just because you're in the work, you're doing the work, you actually see some of these policies that really harm people, and are able to sort of elevate that. And that's a piece of the work that the community health workers help with. So just, to show you a little bit, I'm going to really quickly go through the data. This, we did a large randomized control trial. Oh, sorry, we did a large, this was not a randomized control trial, but we did a large study years ago, where we were able to work with 13 sites across the state to implement programs. I think just what's of note here is all of these patients, the percentage of individuals they're all formerly incarcerated individuals, the high percentage of individuals with substance use disorder, and also people experiencing homelessness, and comorbid health conditions. Just to quickly note on some of the research that we've done is, we've done a randomized control trial that found that individuals returning from incarceration who are randomized to either regular primary care or to our programs, we saw a 50% reduction in ED visits for patients who went to our programs and had that added community health worker elements. We also see it's associated with fewer preventable hospitalizations, and also some progress on an impact in decreasing criminal legal systems outcomes, which is a decrease in parole and probation technical violations, which is actually one of the main reasons people are incarcerated these days, and also decrease in number of days spent in jail if people do return to jail. So we do have some good data that shows that the program, if implemented with fidelity, really does sort of improve health and reentry outcomes. We don't have any substance use disorder specific related research right now, but we are doing a randomized control trial, and that is the one that Hennepin Healthcare is participating in, looking specifically at whether connecting somebody with opioid use disorder to a transitions clinic network program with a community health worker improves engagement in substance use disorder treatment post-release. So hopefully we'll have some data from that soon. And sorry, I know I'm rushing through. It's a lot of information. I think just like some recommendations for working with people returning from incarceration. I will say this with a caveat, ask the question, do you have a history of incarceration? We don't, this is a tricky thing, because with our programs, we ask that if you have extra resources, this is one of these things, right, where it is helpful to know if you are actively trying to engage and improve services for individuals returning from incarceration and have resources for folks, right? It's a little trickier if you're just asking and there's no follow-up. So this is something when we're working with new sites to implement a program. So what we do is we work with sites for a year to implement a program and integrate a community health worker with lived experience. In that case, we're always like, your site should be asking the question because there's somewhere to refer people. So I think there's pros and cons of asking the question. And that's something, if you are able to sort of integrate a cultural humility lens and have resources for folks, that can be an important tool to support people and understand their needs. Offer low barrier medications for opioid use disorder at your clinics. I'm speaking to the choir here, I think. I was just talking to somebody today in Connecticut, and they said they took somebody to their clinic, and their clinic, which is in Connecticut, which is a liberal state, their primary care provider said, I can't do anything for you. I can't prescribe MOUD. There's too many barriers. That is actually not true. So, I think there are barriers, that people put up. So just, having MOUD available at primary care clinics is so important, and harm reduction supplies like syringes, naloxone. Assess, are there other supports that your program could provide to address reentry needs? Like, do you have a medical legal partnership? Are you willing and able to write support letters for patients if they need them for their probation or parole officer? Many times our providers will go to bat for our patients if they're having issues with their community supervision, or our community health workers were. And if, patients ask, we'll call and say, hey, look, I know this person's having issues, but they've been doing an amazing job in the clinic and they're doing wonderful, they're working on these goals. So are there other ways you could advocate for people as a provider, since we have power as providers? Think about ways you can develop relationships with non-traditional partners. Are there ways you can connect to people if they are getting started on buprenorphine in jail or prison, to make sure they're coming directly to you after to get their refills and to get connected to continuity? And then consider ways that your organization can systemically advocate for policies that better support individuals. Are there things that you can show up for? Can you add your voice? And then I'm always gonna just, sort of like prep us, implement a TCM program and integrate people with lived experience of incarceration into your clinical team. I'm gonna sort of skip this slide. And I'm going to skip, there's a little video that I was going to show, but I'm going to skip that just so we have time for questions. And I think this is just a nice quote to end on. So they don't judge you. They treat you like a human being, like you're still a person. That's something that prison takes away from you. And when you get out, society takes that away from you. I think that's what makes transitions clinics so successful. So I'm going to end on that. Sorry, that was I've talked very quickly through a lot of information, and happy to answer any questions. Let's see. Look through the chat.
Thank you, Anna. Do you want to stop sharing, then we can all kind of see each other?
Yeah, thank you. Sure. Thanks. Sorry, I know that was I feel like time went really fast. Sorry, everybody. Very much a whirlwind here. All right. Should I just look through the chat? Also, if folks want to unmute and have questions.
Yes, I don't, we see a fair amount of people like that are coming straight from incarceration. And I think that one of the things that we try to do, like we have some protocols, like, things like we don't do medical opinion forms at a first visit, or we don't, like we generally do that. We will break those rules for those patients because we know that they're in a particularly vulnerable state. So I just think staff education around how vulnerable that particular group of patients is when they come out of prison.
I love that. I mean, I think we had one clinic, the 15-minute late policy, like I was saying, we had one clinic that was like, we have a 15-minute late policy. There's no way we can change that. But what we also have is like, we will never turn somebody away without offering at least one service, right? We might say, hey, we can't get you in to see the doctor. I'll try, but I may not be able to get you in to see a provider. But you know what I can do for you is this one thing, even if it's something very small, right? It's just sort of like, at least showing there's like something that we can do. Like we can reschedule you right now. We can get you some food. We can get you on the way with a full belly. We can like feed you in the, something. So, and I think another thing we've heard too is, front desk staff, providers, certainly, like there's a lot of education and training. A lot of times folks get turned off by like front desk staff at times, and front desk staff admittedly like have a stressful job a lot of times, right? And maybe a little curt. But I think just bringing awareness around, first impressions really are like, do you make a difference, right? So just, it's like a whole team effort, I think, around making folks feel welcoming for many folks, right? Not just people returning from incarceration. I'm looking through. I'm just looking through the chat. I love this cured violence. Yeah, there's actually some great work being done around like community health workers doing violence prevention work, which is really inspiring. Do you have references? Is anybody else? I'm going to look through the chat, but does anybody else have a question or comments or some best practices that you have? I see this question. Do you have references that look at differences between outcomes of coordination of care for formerly incarcerated individuals by CHWs, peer recovery specialists, and other similar roles? are you looking at like if there's an improved outcomes if people are engaged? Was that the question?
I think it's a comparison of the different roles. So there are a number of different roles in integration models. Sometimes it's a social worker, sometimes it's a peer recovery specialist. And then there are several different versions, not community health worker certified, but other versions of that level of training. And how do we parse out what makes the most sense with which population of patients?
Yeah, that's such a great question. I mean, this is such an interesting thing because we here in California, you may have something, I know in Minnesota, you have community health workers like you actually have a very robust CHW work for in the Midwest. Sorry, I know there are other states represented too. We have a peer support specialist certification. We have a community health worker certification. And now there's like different other, which are all sort of similar roles, but in different systems. Like in our system, the peer support is generally in the behavioral health realm. And we see community health workers more in the primary care. I don't know of any literature that has compared them. There's like just very little literature. There just hasn't been a lot of research done around health and reentry, to be honest. We've been doing this since 2006 and we're seeing a lot more interest, which is amazing, but we really don't have a lot of data. And I love this. I love this idea of like looking at, are there specific types of providers? I will say in our network of community health workers, that spans sort of that 48 sites. There are people who are peer support specialists who are actually like certified as peer support specialists and people who are peer recovery support specialists. So we sort of use the CHW as an umbrella term. I think what we've seen is that shared experience is really kind of the key elements, like maybe bringing it across to just like help to ease some of that distrust and really support people. That I think is what we see as sort of a key element.
That's really helpful to hear that, pulling out, regardless of the title or training, what makes the difference.
Yeah, sorry, I know I love that. That's a great question.
Looks like there's some comments from Mark. Mark, did you want to unmute yourself or otherwise I could. I think the last one, be aware that half of prison inmates may not be able to read much. AVS have to be orally explained.
I wasn't aware of the literacy problem in much of my horror patients during my practice years and that was a huge mistake. And some clinics will be quite aware of that. Native American communities know that much more than many non-Native American communities, how frequent poor literacy is. In other words, you may have to ask your patient, do you want me to read the doctor's after visit summary to you? And that's important. And it welcomes them to be accepted into the clinic as not being able to read well. I think that's important. I'm stunned that the prisons and public health services don't offer release strategies following release from prison. It doesn't get more dumb than that. And it's also very expensive because that's when you get follow-ups that are disasters, crimes and criminal activities, blah, blah, blah. So I'm glad to hear you brought that up. But if you want to save money, then don't put people back in prison that don't need it. Provide services for them to get back into better care and life.
Yeah, thanks, Mark. These are great points. And I think people don't realize that people are released without any plans, with very little, if any, medications. I think there's an assumption that folks are released with some sort of with no housing, right? I think there's an assumption that people are released with a safety net, and that is absolutely actually not the case. And yeah, and I love that. And I think that's also, I know I keep talking about the community health worker, but I do think as far as literacy skills, folks may share things that they feel shameful about, like drug use or literacy, with community health workers that they feel a bond with over a provider, right? So I think that's another role. So many times the community health worker will be like, hey, did you know this provider, this client actually can't read, is not able to sort of read through the materials that we need to read. So and there's, I mean, amazing providers obviously doing this work too, who are assessing for these things.
But most physicians don't know this information.
Yeah.
One of them.
Oh, that's great news, Jean, about the transition planning. There is, and just very briefly, there's 1115 waivers, so a reentry waiver right now, which is going to hopefully change the landscape, that is allowing Medicaid to get turned on up to 90 days pre-release for individuals, which is a huge issue as people's Medicaid gets cut off when they're inside. So there's a disruption. So this is potentially like an amazing way to improve continuity of care. And each state is doing, our waiver in California got approved. I think it's just California, Washington, and maybe Rhode Island that have gone approved. And I'm not sure if Minnesota's, if they've submitted, but yeah, some hopefully good things to come.
Well, thank you, Anna, so much. I'm sorry, it looks like we're over time by a few minutes, so I think we should wrap it up, but I so appreciate you coming on and presenting for us. And if anyone would like, any more information, feel free to reach out to me. Is it okay to share your slides from today?
Yeah, go ahead. I'm going to take,
Okay.
the pictures are of patients and we're not able to
sure.
like share them. I'll send you a slide set to share just because we have a release from them that's not like to share with everybody, but I'll send you a slide set to
This is
share.
recorded. We're gonna post on YouTube.
Thank you for all the amazing work that is being done in your
Okay.
communities.
Thank you so much. Sorry, there's a siren outside right now and a little chaos, but thank you everyone for joining. Yeah, we'll see you next time. Our next session is January 3rd. So thank you. Have a great day, everyone.